I do a lot of stuff, but mainly I'm the salvage person. So when I was at Duke for my first faculty position, I was working with Bill Maxner and Murong Shi there, and that's why a lot of those publications are very high profile. But I, again, have found I lean more towards cleaning up clinical messes, and that's why I'm going to talk to you today about some of the stuff we do for pediatric CRPS, because that's an underserved population, as most of us who are trained in chronic pain focus on the adult folks. The slides, I hope you guys can see okay.
Yes.
The
Yes,
goal
yes,
is to give you a rather quick clinical overview of CRPS, which is a disease state I'm sure you all have heard about a little bit, and then focus a little bit on what neuromodulation can do for it, which is a broad topic. It's centered around a case that we presented recently at the North American Neuromodulation Society meeting in Orlando of a young woman who was 12 when she suffered an injury in gymnastics. This was actually at my alma mater in Alabama, in Birmingham, and she was rushed over to Children's Hospital there and worked up by some of the specialists. And they came up with a diagnosis of CRPS due to her severe allodynia, swelling, hair changes. The pain appeared to be more than a single nerve's distribution, and they felt that most likely it is would meet criteria for causalgia. The team there did not have a lot of interventional folks there at the time that would felt comfortable working on a pediatric patient. And so she got mainly medication management, which is appropriate, and treatment with physical therapy and psychotherapy for behavioral help. Along the way, she also got a diagnosis that's sometimes clustered with CRPS, postural orthostatic tachycardia syndrome, something that, again, is interesting in its own right. But this is a case that wound up on my desk from a pain clinician in the community in North Carolina who sent her down to see me to ask about things that we could do. You guys are most likely familiar with complex regional pain syndrome, both from the basic science and the clinical side. Again, this is a nice picture from Dr. Ming Kao's in Stanford. I don't agree with all of it, but it's a nice way to think of CRPS. And on the right is what we think of as end-stage CRPS. And there's normally some swelling, temperature changes, allodynia that presents as some sort of agony. Patients are really suffering. It's out of proportion to what you would expect. There's often some redness, color changes, and in late stages, we'll often notice some what physicians will describe as tremors or dystonia, where the muscles are spasming. You'll see patients kind of in a weird curled up phase with their arms locked up. And there's a lot of mnemonics for this, but they will say this is one of the most painful diseases, similar to trigeminal neuralgia, one of those things that people will complete suicide over. And the primary treatment is not medications, but really the working out and physical, appropriate and intensive physical therapy. However, medications and interventions are key to facilitating that, and that's where patients normally get engaged with me. There are, unfortunately, a lot of things that look like CRPS, and this is where the diagnosis is likely overrepresented. And unfortunately, we see that when we'll talk a little bit about the research models. But there are a set of clinical criteria that you guys have no doubt heard about, the Budapest criteria, that cover 4 sort of domains: sensory, vasomotor, pseudomotor, and motor trophic. And you can think of what neuronal populations or support cells would modulate that. But in general, we're looking for clinically at the time of the event that the patient must report 1 symptom in 3 of the 4 classes. So, back when 2 years ago, did this little girl have changes sensory, vasomotor, pseudomotor, and motor trophic? And the answer was yes. At that point, she did. When I saw her, the patient, still had maintained. Oh, Dr. Emory. Would you guys like to stop now to give questions to Dr. Emory, or you want me to keep going? Because he
Please.
did have a great talk, and I would love to.
Well, I hate to interrupt yours, so I'm so sorry about that. I just
Dr. Monik?
Yeah, I think you can continue. We can until 4:30. We can invite some questions.
Okay, just because Dr. Emmerich does have to run, I don't mind just taking one or two questions for him if you like. But
Doctor, anyone wants to ask any questions to Dr. Emmerich?
Dr. Emmerich, actually, I had a question for you, so it's really for myself.
Sure.
How long can you keep that model running?
Yeah, that's a great. You're talking about the imaging, I'm guessing.
Yeah, the window model. So you're doing a hemispherectomy?
Bilateral, actually. It's actually, so the mouse will be stable for typically about an hour and a half, but up to 3 hours, depending on how well you can do that removal of brain tissue.
Probably out in Stanford. And this is a model where, again, it's got high face validity. You break a extremity, and breaking it alone isn't sufficient. And this is a point that I make clear to my patients, that it's not the fact that a trauma happened. Really what we have to do is we also have to cast it. We have to immobilize that extremity in the animal. Casting alone actually appears to be sufficient to get some parts of this phenotype, the allodynia, the swelling, some of the pseudomotor changes that we're looking for. But the combination creates a CRPS-like state in animals that resolves within 5 to 6 months. And again, it's a nice model for studying things. And again, having done a little bit of animal research, it's probably one of the ones I prefer if I had to pick something to do. But God knows I would probably never do that. Now, pediatric CRPS has a similar clinical phenotype, but there's really not animal models of this. The phenotype, again, shows up in extremities, upper extremity, lower extremity, but predominantly in pediatrics in the lower extremity in most studies. That's different where in adults, there's a discrepancy whether it's about even in upper or lower or just an upper. But you see everything else identical, allodynia, hyperalgesia. There's a shared phenotype in here, even though the biology of pediatric pain is different. These patients tend to have favorable outcomes, but again, it's not clear whether there's a different underlying biology to this. One of the things that you will see from the animal models is that there may be an autoimmune component or an immune-mediated profile to this, and that may be a separate disease entity. There's a lot of folks that treat CRPS with IVIG or Plex to remove immune mediators from a system, and that may really just be treating a small fiber neuropathy that we probably don't see in pediatrics. But the treatment is the same. Medications, which we loathe to give, most of our medications are not FDA approved or cleared for children, even though some are. The gabapentinoids, which are one of the weakest, most people don't like gabapentinoids, but they are actually studied for pediatric seizures, so we do have data for that. They don't seem to be as clinically effective as we'd like. Most of our psychotropics or antineuropathics, not something we want to give to a developing brain. So the mainstay is play therapy, behavioral therapy, physical therapy that's kind of based in play, psychological support, because there is a strong psychological and social component to this. And that is, again, something we can discuss, but not something we can easily assay perhaps in animal models. And then where I get involved, which is I poke things. We do a lot of different interventions. The majority of these interventions are sympathetic blocks. And then let's get into the meat of the talk, or neuromodulation. The definition of neuromodulation I teach people is that we're electrically or chemically altering nerve activity, and it's in a targeted manner. That's a little different than giving someone a Cymbalta or a gabapentin, where it's not really targeted. Here we're finding a specific nerve or set of nerves or neural structures and trying to modulate it, increasing or decreasing activity. The classic types of neuromodulation that people do, and your clinical group is very familiar with this, is spinal cord stimulation. I'm using Medtronic primarily because they're physically located close to you guys. But there are now, batteries that we put in patients that are relatively small, that could fit a pediatric patient. These are percutaneous electrode arrays or paddle electrode arrays that are all placed generally over the dorsal columns in the spinal cord. We have now different types of waveforms. Back in the day of where we used to focus primarily on gate theory, we used conventional stimulation, 50 hertz stimulation that was activating these A beta fibers that are running in the dorsal columns to create a paresthesia. And that paresthesia was thought to block pain sensation. But nowadays, with different electrical stimulation modalities, stimulation waveforms that are non-physiologic, with burst stimulations or rapid pulses of energy, or 10 kilohertz stimulation, what we appear to be seeing is changes in the activity of neuronal fibers deeper in the dorsal horn and some of the lamina and some of the interneurons, as well as some changes in the glial support cells based on some of the waveforms and data that we have. So again, lots of things that we could, in theory, try. And this has been done. This has been well described in pediatric patients, and it is very successful. On the left, this is a paper from, I think, early 2000s, if I remember correctly, of a case series for pain medicine is actually pretty good work. 7 patients at the time that were aged 11 through 14 that had CRPS. This team based out of Europe had placed percutaneous leads. So percutaneous leads are put in with a needle. There's no bone removed. Those leads were placed over the dorsal column in the thoracic spine to cover the lower extremity, as well as one case for upper extremity CRPS where they placed it in the cervical spine. 2 of those patients went on to get paddle leads, where the majority were implanted with percutaneous leads. And that's primarily because the percutaneous leads are easier, less invasive. And so in this population, most people would want to do this. On the left, again, is one of the things that you see in patients with CRPS. They develop these contractures, they develop that hypertrophic limb. And it's very difficult because some of this pathology is driven by how they're coping with it. That crutch handle is likely cutting off lymphatic return. The patient not moving it is creating venostasis. The patient not willing to touch it is going to create hypertrophy because they're going to have dead skin on it. And so again, it's sort of a self-fulfilling prophecy to some extent that we're trying to break. But again, spinal cord stimulation, very well established and on most insurance algorithms for approval. This is another case that really makes me angry. This is a mother and daughter, both the diagnosis of CRPS of bilateral lower extremities, both that have paddle leads in. The daughter got that placed when she was in her early 20s. And that paddle lead is something that is surgically implanted. It requires removal of a small amount of bone and is very uncommonly removed and limits a lot of our options. And so these are the types of things that make me want to be more vocal about it. Is I'd like to make sure neurosurgeons, spine surgeons are aware that there are other ways to do this, because a paddle lead is not optimal, even though that is what most of us think of for CRPS. These days, neurosurgeons are doing more and less invasive forms of stimulation. This is a dorsal root ganglion stimulator that's placed percutaneously. These wires are coming out the foramina laterally, stimulating the dorsal root ganglion directly for, again, patients with lower extremity pain. This is a nice system that allows you to capture a specific DRG, L4, L5 in this case. And again, the difficulty is that even though we may think this is a pain state mediated by sympathetic neurons or pain state mediated by changes in the spinal cord, stimulation anywhere along this axis appears to cause benefit. And so where I'm trying to add some value here, this is where I really like to add value. I do a lot of intrathecal pumps. I'm a huge fan. And this is a great example of neuromodulation that used to be done for CRPS. This is a way to deliver medications targeted to a specific region of the spinal cord, where we can deliver high concentrations of local anesthetics, medications like baclofen or opioids, or novel peptides such as the conotoxin ziconotide to the spinal fluid. That medication doesn't act on the spinal fluid, but it can impregnate, kind of marinate the steak of the spinal cord. But this is something that, when I was, we managed about 150 of these pumps in Durham, and it was a huge burden. Part of the reason a lot of clinician scientists don't use them, even though they're a great research tool, is because they are demanding. It's a passion therapy, not something that you're going to make money of, because it takes a lot of time And it's a burden for everybody involved, patients included. But it's a great therapy, but it's used as salvage because of this burden. And so where I'm asking you to think of is there a better way? And for me, the better way is perhaps peripheral nerve stimulation, which is not something that I would have told you 5 years ago. And peripheral nerve stimulation is something that was developed actually prior to spinal cord stimulation, which makes sense, less invasive. Folks did great with putting little electrodes on the nerves. Patients and authors, so in theory normals, had analgesia, both the induced or spontaneous pain. These systems, though, were structurally awkward and were challenging because you didn't have equipment designed for it. And so you'd have to do large open surgery. In my practice, we would use off-label things such as the InterStim, which is a sacral nerve stimulator, to do sort of nerve root stimulation for different states, or use those same leads with a small battery in the periphery. It is a therapy that is effective, but has lots of mechanical complications. And the problems are the wires move, the wires break, and the wires erode through the skin because the wires were never designed to be in the periphery. This is an example of a patient that is a peripheral occipital stimulator. The occipital stimulator starts behind the ear, and that dotted line kind of runs back down across the neck over the sternocleidomastoid into a pocket on his chest. Not a lot of fun. When he moves his neck, that thing pulls and tugs. Highly effective while it's in place, but when it breaks, it's very challenging. You guys may have seen the push from NIH for the SPARC, the peripheral neuromodulation. And this really developed a lot of new hardware and funded some good research onto this. The newer devices that we have now are more flexible, have integrated anchors, and are FDA approved for this therapy. And for pediatric patients, this is ideal. There's no big bulky generator. There's no permanent scar. This can be all placed with needles. I'm going to talk to you specifically about one company because that's the device that we used in this case. This is an FDA-approved stimulator for acute and chronic pain, something that would be easily amenable to small animal models for your basic scientists because it's a relatively cheap product. The magic of the product is that it's a wire. The wire is a single, looks like a single item, but it's actually a group of wires that are thinly wound like an old school phone cord. That old school phone cord aspect allows it to scar in place and holds it in place. It has one large electrode. This is the largest single electrode, even though it's just really one electrode. This whole part that makes this hook is not insulated and is active, where everything that is above that is coiled up helically and insulated. It's designed to actually stay in place for up to 60 days as the FDA approval for adults. And after removal, it provides durable analgesia, which sounds weird. And when you talk to their basic science guys, they wave their hands about central sensitization. But they do have clinical data suggesting that. And it's connected to an external generator that the patient can wear and is changeable, where the patch is changeable every day to every other day, and the dressing is changed every week or so. In this case, it's been used in, again, multiple sort of pain states now. You're trying to place this needle using ultrasound or fluoroscopic guidance close to the nerve, but not right on the nerve. And what this allows is sort of a uniform electrical field that activates the nociceptive populations without creating painful motor stimulation and jumping. The stimulation waveforms tend to be in the conventional range, sort of the lowest frequency they have a motor program is 12 hertz, the high frequency for them is 100 hertz. So nothing like the ones that we talked about in the spinal cord space. But the stimulation appears to, over time, reduce neuropathic as well as nociceptive pain. So both pain from acute surgical states as well as chronic pain states such as phantom pain in this case, or in our case, CRPS. It's designed to be relatively low cost, costs about $8,000 for a 2-lead system. And again, it's temporary hardware, which for pediatric pain states is important. It's not MRI safe. So while the wires are coming out of the body, a patient can't get an MRI, but it's easy enough to remove. There's a small chance that the wire breaks. Their data say about 5%, but the patient can still get an MRI with that if needed, which again, for folks in their 10s to 20s may not matter, but for the lifetime of that patient is a significant thing to consider. One of the interesting things about this poster that we presented at NANS was that we used to capture sciatic and femoral nerves using an anterior approach. And this is one of the nice things about the peripheral stimulator space is that you've got a lot of ability to be creative with things. The anterior approach to the sciatic nerve isn't one that we think about a lot as clinicians. Most anesthesiologists will do a subgluteal sciatic kind of in your butt, or behind your knee, the subpopliteal or fossa approach. And those are adequate for surgery for most lower extremity things. The anterior approach is something that I started doing because it allows me to capture all three of the nerves that run down the leg. Most of the time, we really only need the femoral and the sciatic, but the approach puts the obturator nerve in play as well and puts the dressing kind of on the anterior surface. And all we're doing is using a ultrasound, finding mid-thigh, trying to visualize the sciatic nerve down deep underneath the adductor muscles, and trying to find a trajectory that allows us to go nice and shallow in through those adductor muscles, those big muscles on the inside of your leg, down to the sciatic nerve. And we can see both motor and sensory stimulation. With a patient awake, they can tell us that they feel it. The green arrow shows a trajectory that also allows us to appropriately find the femoral nerve for patients where we wanted to find both. In this patient's case, that's what we did. It has no long-term scars, no significant trauma. The patient was actually awake. Working with pediatric patients, you learn how to hold their hands a little bit more. My jokes have gotten a little bit more PC. And the major thing for CRPS patients is there's no trauma, no significant limitations in activity. And again, any therapy that we do to them, any surgical procedure is a risk for developing more chronic pain. And so the peripheral nerve stimulation allows us a way to kind of avoid that. It's a temporary PNS. And that reinforces that this is going to get better. My expectation is that you're not permanently labeled as a CRPS patient. It can be retreated, and it does not permanently alter the musculoskeletal system. We're not removing bone, we're not removing muscle, we're not creating new scar. This patient, in our case, had over 50% relief, came off her gabapentinoids, came off her SNRIs, still has residual pain, and still struggles a little bit with activity, but was doing better at the 9-month mark when we last interacted with her. And so again, it's a good example of therapies that as pain doctors we can do, and unfortunately is something that our pediatric colleagues need to be aware of. And so for us at got good contacts at CHOA, the Children's Hospital of Atlanta, and we have a robust pediatric pain group there that I'm trying to get comfortable with these therapies. Most pediatric providers do a lot of medication management, but perhaps not as much of the rest. And with that, I'll open it up to questions, and I'm going to leave this slide up to answer this is Dr. Belfort's question. Is that okay?
Yeah, please go ahead.
So Zach, the lead plays in short access to the nerve, and how much length of the lead needs to be close to the nerve in order to be effective. So this system is unique in that for the older faculty that were never ultrasound trained and just its nerve stimulator